It's a pleasure to be with you. Thank you for the organizing committee for the invitation. It's a pleasure to be in this city, beautiful city, for first time in my life. So I'm going to give some lights on some difficult or non-eligible, non-variable cases of non-eligible for mitral TEER, and we'll just go over one case at the end to show how to deal with such patients. So, sorry, it's not moving. Okay, so these are my disclosures, and it's clear now that we are in approaching the mitral valve management, we have to understand the etiology of the cause of the MR, whether it's a primary or secondary. But commonly, we are seeing a mix of both etiologies in the same patient. Now, from imaging point of view, we have to look at carefully at the anatomy of the mitral valve and try to decide whether it is suitable or not suitable. However, I like to use this terminology, it's a favorable or unfavorable, because as your experience grow up, you will be able to do more complex and less favorable cases. As a startup, when I started the interventional program of ECHO, I was looking for these patients where it is ideal. Central pathology, no calcification with the large mitral valve area, enough posterior leaflet length, where if you see this patient or you deal with such patient, you will end up with a very favorable result with mild MR and low gradient. However, life is not easy always. We always see such patients like rheumatic mitral valve with a small mitral valve area, restricted posterior mitral valve leaflet with high gradient. And I was thinking always why the smaller mitral valve area will end up with, it is less favorable, but this is clear by this study where it showed that using one clip will reduce the mitral valve area between 52 to 57% of the original mitral valve area or the baseline mitral valve area. And if you add one more clip, you will end up with more 25 to 34% reduction further in the mitral valve area. So it's clearly that you don't want to use to deal with patient with mitral valve area less than 3 centimeters square. The very short posterior mitral valve leaflet is a challenging, let's say, condition where we are dealing with very short and difficult to grasp. And it's not only the length of the posterior mitral valve area, the posterior mitral valve leaflet. It is all the shape of the leaflet. It's usually curvy, and this restriction which make the grasping of this posterior mitral valve leaflet difficult and challenging for interventional colleagues. Now, another challenging condition, which is the severe MAC, this will make the posterior mitral valve area is very short, restricted, and will put a great risk on the leaflet for if you grasp that leaflet to rupture or to tear. However, saying that, I came across this study from Spain where they did actually deal with the severe MAC patient with the mitral valve TEER, and they have a good result compared to the control, but also saying we have to mention that there is a risk still of cord rupture and conversion to surgery. So you have to be careful with dealing with such patients with mitral valve TEER. I personally prefer to send these patients to cardiac surgery rather than dealing with them percutaneously. Deep cleft or indentation, another challenging condition for TEER, where you have to make sure it's not a true cleft, not extending to the annulus. If it is not, it will be also challenging for the strategy and planning of treatment, where you don't know how to treat them ideally, but now we are using the A technique to deal with such patient. But if it is like this image, if it is a two cleft, really I don't know how to deal with such a condition. We didn't do such a case. We use only one cleft rather than two clefts. So it's another challenging condition where you have to think deeply how to deal with such patients. Another condition which is I face not that frequently, but I would say we have those patients with a small left atrium. And I'm not sure if it is an accurate terminology to call it a small left atrium, but rather the shape of the left atrium is a small in the vertical axis. I would think that the dilatation, it is more of a horizontal dilatation rather than vertical dilatation. This makes the septal height low for your transseptal puncture, and maneuvering the device will be more difficult in this small LA. And like this patient, we were doing the perpendicularity in the ventricle, and this will put a high risk for complication during the procedure. So it's not that common, but you have to be careful for these patients and expect the worst. So I'll present this case, and I'd like to hear from you your opinion. A 76-year-old male, diabetic, with history of MI, post-BCI to LAD in 2022, ejection fraction severely reduced with 25%, with recurrent admission due to decompensated heart failure despite optimal guideline-directed medical treatment. A recent coronary angiogram showed patent state with no obstructive coronary artery disease. Not candidate for CRT because he's a narrow complex QRS, and this is his transthoracic echo. So you can see that it is severely reduced LV function, dilated left ventricle, and it's clearly a severe MR. But the question, what do you think about the posterior mitral valve leaflet? So it's a functional, let's say. Do you agree or not? We were really concerned about the posterior mitral valve leaflet, and we thought that there is some rheumatic changes. The transesophageal echo, you can see there is a wide gap, severe MR definitely, no doubt, but again, there is a great concern about the posterior mitral valve leaflet. The gradient was 3 to 4, that's added to our concern in discussing this patient for mitral valve TEER. The mitral valve area, now we had two measurements, one is 3.2, one is 3.7. Probably the 3.7, we a little bit extended our tracing, but clearly also you can see the reverse in the pulmonary vein. This is a STS score. You can see that the morbidity and mortality is quite high, 17 to 20%. And the cardiac surgeon in that hospital, actually we were doing in a different hospital, so the cardiac surgeon, he said, no, I will not operate in such patient. And there was no percutaneous mitral valve replacement, no tendine in that facility. So what do you think? Should we proceed with mitral valve TEER or not? So we decided to, let's try. And this was after using the XTW, and after grasping of the mitral valve, there was really a wow in the cath lab, because there is almost elimination of the mitral valve regurgitation, but the problem was this. the gradient 12. So now the discussion was very, let's say, hot in the cath lab, what to do. So the options we were discussing, abort, send for surgery. The surgeon, he said, no, I cannot take, I will not take. Then the other option, as I said, it's percutaneous mitral valve replacement. It was not available in that facility. We remain with NTW, NTR, XTR. So from expand registry, we know that there is no difference between XTR and NTR in the mean gradient. So we thought the same, using NTW will not change the outcome, so we remain with XTR and NTR. Unfortunately, NTR was not available in the room, so we used the XTR. After careful adjustment of the perpendicularity and positioning of the mitral valve of the clip, we end up with this result. So the MR is in the range of moderate, if you agree with me. And the gradient was 7, and there is no pulmonary flow reversal. What made us more, let's say, happy is the hemodynamic results. So the LA pressure, the mean LA pressure dropped from 45 to 20. The V wave from 65 to 40, and the next day transthoracic echo, the mitral valve mean gradient remained the same, so 6 to 7 with same degree of MR. So we thought it's a reasonable good result, taking all the circumstances the patient has and all the condition. So I will conclude that careful assessment of the mitral anatomy and morphology for better selection and outcome. At some time you have, actually not sometime, frequently you have to balance between MR reduction and stenosis and complications. If you are starting up your mitral valve intervention, start with more favorable condition, and as your experience grows up, you can do more complex cases. And by this, I would like to thank you for listening. Thank you.
Thank you, Dr. Albinmousa. We saw how you can deal with difficult situations and especially making decisions in the operating room. At the end, we are going to have questions for you.
Thank you.
So thank you very much.